Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today's episode will be a question-answer session. I have a couple of listener questions to go over, and I'll also invite you at the end of this to share your own questions for a future Q&A episode. The best way to do it, and the way that you'll hear the questions today, is to use the link in the show notes to submit an audio question. This way I can play your question on the air and discuss it. So let's hear our first question today.
Hi, Dr. Fred. I have a question for you. My maternal grandmother, died of pancreatic cancer. Should I be screened? Is this a genetic type of disease? Can you address that in one of your podcasts that I absolutely love? Thank you.
Okay, so that's a really good question that I don't actually get asked that often in the office, although people definitely want to know about pancreatic cancer, and some people do ask for screening. It's not the most common thing to be asked about. So it's a good thing to review today, and I think when people hear the word pancreas in just any type of setting, the most common thing that people think of is pancreatic cancer, because usually people don't really talk about your pancreas. Like, you don't see people talking about pancreas health online. It's just not like a organ that a lot of people know about, except when they hear that Uncle Bob has pancreatic cancer and it's bad. You know, that's usually when people hear the word pancreas, it's associated with cancer, which is a bad association, obviously. So the pancreas typically is sitting there silently doing its job. It's making hormones, it's making digestive enzymes, and it's not until it acts up do we really learn about its function and all about it. But what's up with the pancreas, and why is pancreatic cancer so bad? Well, I think the main reason is that when someone gets diagnosed with pancreatic cancer, it's often diagnosed at a later stage because the initial symptoms are pretty nonspecific. So people for years to months before they really get diagnosed with pancreatic cancer will have vague type symptoms, some fatigue, some nausea, some mild upper abdominal pain, maybe a change in the bowel habits, but there's no like real localizing symptom in the beginning. This is a generalization, of course. You know, lots of people can have different symptoms, but you hear these stories when people later on go on to get pancreatic cancer diagnosed, and you have this like year or two where there's these vague symptoms. And it's hard because if you tested every single person who came in with mild upper abdominal pain or a little nausea or a little fatigue, you would be scanning or, CAT scanning every person that came into the office, which is not really feasible either and can cause its own problems with all the radiation exposure. So pancreatic cancer often doesn't get diagnosed until it's at a later stage because it's nonspecific in the beginning. And it's not until the more specific symptoms come out, which is further weight loss, jaundice, where your skin turns yellow, or more like localized, more chronic, or more severe upper abdominal pain, that the cancer gets diagnosed by imaging, by a CAT scan or an ultrasound sometimes, or an MRI, and then eventually you get the diagnosis, and by that time it's already at an advanced stage where the cancer is either invading some other organ or it's spread somewhere else in the body and it's not really resectable anymore. You can't cure it with surgery anymore, and now it's just a matter of time, unfortunately, until the disease takes the person's life. So you want to diagnose any cancer early if you can, because that's when the options for treatment are the best. And this is when we talk about screening. We've talked about colon cancer screening lots on this show. That's my forte. But pancreatic cancer screening is also a thing in a certain subset of people. So before we delve into the question, it's important to understand what the average risk individual faces regarding pancreatic cancer. So it's a lot less common than some other cancers that we deal with, but it's still not an uncommon cancer. The risk of a random woman developing pancreatic cancer over her lifetime with no real family history is about 1 in 60. So 1 in 60 women will go on to get pancreatic cancer. And in men, it's a little more common. It's 1 in 56 men. And that's this year's stats. So that's with no family history, no risk factors. That's just the average risk of developing this cancer. And once it's developed, or once you have it, what are the stats regarding survival? So some cancers are more survivable than others, and unfortunately, this is one that is not great in that department. So in terms of the disease, If you have localized disease, meaning it's just a tumor in the pancreas and is not broken out of the pancreas and it's still something that can be operated on, the 5-year survival, meaning survival compared to your peers after a 5-year interval, so the relative 5-year survival, is only 44%. So only 44% of people will still be alive in 5 years, even with a localized pancreatic cancer. If the disease has spread in the abdomen near the pancreas, but not really distantly throughout the body, the 5-year survival is 16%. Also not a very good number. And in the worst case scenario, if the pancreatic cancer has spread to distant organs through the bloodstream and it's setting up little foci of cancer throughout the body, the 5-year survival there is only 3% compared to other people without pancreatic cancer. So it's a pretty grim diagnosis. And if you have risk factors for it, it's not unreasonable to consider screening. So who do we screen and what are we looking for when we do screening? Well, we're looking for some type of lesion in the pancreas, usually a cyst or some type of growth in the pancreas. And there's multiple different types of cysts and growths in the pancreas, and they all have different risks of developing into cancer. But the important thing is just finding these things on imaging, and then once you figure out what's there or what's not there, you can kind of plug yourself into some type of algorithm or surveillance program. And once you see the lesion, if it's a cyst of some sort, it's measured, you look at the characteristics of the cyst. All this stuff is kind of beyond the scope of a simple question like this, but you at least will be kind of plugged into a surveillance algorithm, meaning that you'll follow this thing now in the future, and hopefully if it starts growing, you'll be ahead of it and you'll be able to do something about it before it turns into a cancer. So the point is, these pancreatic cancers don't start out of thin air. They start as a small lesion, just like every other cancer starts as a small growth and then slowly grows into the real tumor that does the damage. And that process can take time. It could take months, years. It's a matter of early detection. If you could pick it up early, the precancerous lesion and the precursor to the cancer, then you can do something about it more aggressively. And that thing that you can do is you can remove it. So we're talking about getting surgery on the pancreas, prophylactic surgery before something turns into cancer, or getting it out, that is the cancer out at an early stage, which is a risky thing as well. You know, pancreatic surgery is no joke, and you don't just casually go in and have half your pancreas taken out for no reason. So it's a big deal. So there are definitely harms potentially of doing screening in people for pancreatic cancer, because the chances of reacting to something too aggressively and taking out a cyst that may never turn into cancer and causing major issues after a surgery is a very real thing and happens frequently when you're talking about pancreas surgery. The bottom line is, who do you screen and how do you know if you should be screened, and what are the kind of things to think about? Well, as you can imagine, it's kind of like, it depends on your family history. So if you have a family history of pancreatic cancer, it's a reasonable thing to think about screening, but it really depends on who has the history. So if it's like your second cousin's brother, it's probably not a big deal for you to get screened. I wouldn't necessarily do that, but it's really a matter of first and second degree relatives. So first degree relatives, parents and siblings and children, technically. If at least 2 first degree relatives have pancreatic cancer, then it's reasonable to consider yourself at high risk and to get screened. And that being said, for our listener's question here, she's talking about a second degree relative, a grandparent, and a single grandparent having pancreatic cancer doesn't really meet the criteria to get screened. Now, if you have some other symptoms or some other issues or maybe some personal risk factors plus that family history, it's a worthy thing to discuss with your doctor, because everyone's individual risk depends on both their family risk but also their individual risk of their own risk factors, what they do, what their medical problems are, and I'll go into that toward the end of this answer. But it's just one grandparent has pancreatic cancer, then it's really not necessary to get screened. But if 2 first-degree relatives have pancreatic cancer, then it's definitely a thing to think about. Now, the risk of a person developing pancreatic cancer, if they have a family history, goes up with the number of relatives that have the disease, as you could guess, right? That makes sense? Now, if there's 2 first-degree relatives that have pancreatic cancer, meaning a parent and a sibling, or 2 of your siblings have pancreatic cancer, then your risk of pancreatic cancer is about 8 to 12% over your lifetime, which is like 6.5 times higher than the average person's risk. It's a pretty significant risk. Now, if there's 3 first-degree relatives, your risk jumps up to 40%, a huge number. That's 32 times higher than the average person's risk. So if you have 3 first-degree relatives, meaning 2 siblings and a parent or some combination like that, then definitely you should be screening yourself. And you should also be thinking about getting genetically tested, because that is a serious signal when multiple people have pancreatic cancer that are directly genetically linked to you. Now, if you have an uncle with pancreatic cancer and a grandma with pancreatic cancer, it's very hard. Like, these risks are not really as well defined as the first-degree relatives are. but it's all stuff to talk to your doctor about, basically. And the kind of doctor to talk to about this, really, it's a gastroenterologist or, potentially an oncologist or someone like that. But the primary care doctors, they may not know exactly who to screen. And even us GI doctors sometimes have to kind of think about this and look it up and talk about all the other factors that kind of play into screening and make an individualized decision with the actual patient sitting in front of us, because these are just loose guidelines. And the evidence here is not amazing. Like, there's not like amazing evidence for screening for pancreatic cancer. It seems like if you screen people and you pick up precancerous lesions, there is evidence that it does reduce death or mortality from pancreatic cancer if you go in and do resection of these large cysts or these lesions that are growing into pancreatic cancer. So if you pick them up early and you do something about it, the overall balance is favorable. Like, it's good to pick things up early here. There is a benefit. That being said, it's a hard decision sometimes to make, because a lot of times you screen people or you just do imaging in general, and you find a lot of these incidental little pancreatic cysts and things that probably mean nothing. And then it raises everyone's anxiety, and you're going crazy screening them and scanning them constantly, and potentially you're at risk of causing harm with some other follow-up tests and biopsies and things like that. So there's always two edges to the double-edged sword of medical testing. And this is the reason why you have to talk to your own clinician and kind of weigh all the risk factors. It's not a black and white type problem. So who else should be screened for pancreatic cancer? It's really people with genetic syndromes. So there's a bunch of genes that are associated with pancreatic cancer, and this is not going to be an exhaustive genetic topic here because it is very complicated and can be boring for some people to listen to. But that being said, Lynch syndrome is a thing that we see a lot of. It's normally a colon cancer, stomach cancer, and endometrial cancer type syndrome, but it's a very common genetic syndrome, and it also includes a risk of pancreatic cancer. There's other well-defined genetic syndromes like BRCA1 and BRCA2, ATM, which is something we see a fair amount of on genetic testing, and also PALB2. And these are all genetic syndromes that you would get picked up on testing that you did because someone in the family or yourself developed some type of cancer. You send off a test for these genes and you find something lights up, and then now you have to look for all kinds of other cancers that are associated. And again, this is more for like your doctor to tell you about it. I don't expect people to go and get tested for genetic conditions based on just a fear of getting cancer. But if you have something like this in the family or you got tested for it, these are also things to think about when you're screening for pancreatic cancer. There's also some other syndromes that are very highly associated with pancreatic cancer. Peutz-Jeghers syndrome is probably the most risky, and you would know if you had that most likely because it has a lot of findings on physical exam. But also something called hereditary pancreatitis is a very, very high risk of developing pancreatic cancer over time, which you would have multiple people in your family that develop pancreatitis. That's not due to alcohol or some other common cause of pancreatitis. So these are all things more like for the clinician to deal with, not for the average person to think about. But the average person, it's really all about the family history. So if you're going to get screened for pancreatic cancer, when do you start doing it? It's hard to say, but for most people, the age of 50 seems to be where it's chosen to start screening for pancreatic cancer, or you do it 10 years younger than the person in your family that was diagnosed with cancer. So for example, if mom had pancreatic cancer when she was 45, you wouldn't wait till you were 50 to get screened. You would get screened at 35. But if you have a genetic syndrome or one of those other more uncommon syndromes that we talked about earlier, then you would get screened at an earlier age. You would not wait till 50 years old. So these are general, loose guidelines. How often should you screen? It depends on the person again, but somewhere around every year seems to be the consensus. So you do some type of screening test about every year if you're at high risk, because these things can start out of nowhere and you want to catch them early. And if you wait 2 or 3 years between screenings and you catch something 3 years in, it might as well be as good as no screening at all. So every year or so seems to be the guideline, but of course it depends on the individual risk for pancreatic cancer. And how do you do it? Well, the best non-invasive way to do it is with MRI. You do an MRI of the pancreas. It's a pretty easy test as long as you're not terribly claustrophobic. You lay there, they take a lot of pictures, there's no radiation involved, and they get a decent look at the pancreas that way and can pick up small lesions and other problems there. If you're at really high risk, sometimes you do a test called endoscopic ultrasound or EUS. It's a little more invasive. That's where you go to sleep and we do like an endoscopy type test where we look down with a little camera at the pancreas using a little ultrasound probe on the end of the camera, and you can see the pancreas up close and personal, and you can take little biopsies of the pancreas if you need to. That is a better quality test, but it's also more invasive with associated risks. One of the problems that comes up with the screening test is that if you do an MRI or a CAT scan or something like that, and it's equivocal and you can't really get a good look, then sometimes you're kind of forced or recommended to do an EUS, and the EUS has some risks involved with it. So you may get a biopsy, you can get an infection or a bleed from that, or you can develop pancreatitis or inflammation in the pancreas from a biopsy, and it may all be for naught. So nobody knows for sure what's going to happen when you go for these screening tests. Are we doing each individual patient more harm than good? We really hope we're doing more good than harm, but you just never know. But I guess the bottom line is it's an individual decision based on your family history and your individual risks, which we have to go over because that's the most important thing. Again, you can't change your family history. You can't change your age. You can't change your gender when it comes to cancer risk. But what you can change are your modifiable risks. So what are the things that are associated with pancreatic cancer that you can actually do something about? The big things are lifestyle, of course, like that's obvious. Smoking, probably the single most modifiable risk factor, is responsible for like 25% of pancreatic cancer. So 25% of pancreatic cancer can be attributed to people who smoke. So if you are smoking and worried about pancreatic cancer, seems to make sense to not smoke. The other big risk factor is chronic pancreatitis. So typically you see this in people who drink a lot, but you can see it for other reasons too. But people who get repeated episodes of pancreatitis or inflammation in the pancreas, that chronic inflammation increases the risk of developing pancreatic cancer. And at the same time, makes it harder for us to see the pancreatic cancer because the pancreas looks abnormal on imaging. It's very hard to get a clear picture of it because of the chronic inflammation. And you can have a small tumor or something like that hiding in the pancreas and very hard to detect. So it's like a double whammy right there. So chronic pancreatitis, often from alcohol use. Even if you're not getting severe pancreatitis where you're ending up in the hospital over and over and over again, just the chronic alcohol use at a higher level can cause changes in the pancreas that last a lifetime, scarring and other problems. So you want to avoid that as well. And it's debatable if alcohol itself causes pancreatitis just from casual use. I'm sure it's not helpful for the pancreas, but the data is still not really rock solid on that, but definitely excess drinking seems to be a risk. The other big risk is obesity. Obesity increases the risk of pancreatic cancer by about 20%, and that's also probably because of inflammation and other risk factors that cause cancer that are related to obesity, just like other cancers like colon cancer and many other cancers. New onset diabetes. This is an interesting one. So you see this occasionally in the office. Someone comes in with risk factors for pancreatic cancer, such as they're a smoker or they're obese, or they have a family history of like one person in the family, and then this patient in front of you develops diabetes. He said he developed diabetes 6 months ago or whatever it is, but kind of out of the blue, was not diabetic, all of a sudden is a bad diabetic and the sugars are through the roof. You have to wonder, did that person develop pancreatic cancer? Because that seems to be an association. In people who get diagnosed with pancreatic cancer, often they present first with like new onset, poorly controlled diabetes, probably because some of the pancreas is not pancreas anymore. Now it's tumor and it's not functioning and making insulin anymore. So they were probably already on the way to diabetes and that just kicked them over into the diabetic category. But you have to watch out for someone who's at risk for pancreatic cancer, starts losing a little weight and develops diabetes all of a sudden. Someone to send for a CAT scan for sure. And I've definitely picked up pancreatic cancers that way before there was any real abdominal symptom. It's a little scary, right? The other thing is diet. So typical diet changes that we recommend for everybody: eating a low inflammatory Mediterranean style diet, watching out for processed red meats and too much processed food and all that stuff that we've covered a million times in this show. That all kind of goes for pancreatic cancer as well. So that's kind of the bottom line for pancreatic cancer screening. It's reasonable to think about it if you have a significant family history, meaning at least 2 relatives, preferably first-degree relatives that have pancreatic cancer. But also, all the screening in the world is not going to protect you from things that you can do to yourself. And if you can avoid the bad things that cause pancreatic cancer, meaning smoking, obesity, poor diet, and too much alcohol, then that beats out screening most days of the week. So whether you're going to get screened or not, try to do the right thing in terms of the diet and lifestyle to avoid getting pancreatic cancer. All right, this episode has gone on long enough talking about just one question, because I can never stop talking, it seems like. But if you like these kind of Q&As, please go leave me a question. I'll post the link at the bottom here under the show notes, and you can click and leave me an audio comment on your iPhone or whatever, and it's very easy to do, and I can answer it in a future episode. I did have another question to answer, but I'm going to save it for the next episode because I don't want this to be an hour-long discussion on just 2 questions. So make sure to tune in next week when we talk about what other factors cause diverticulitis, with a focus on stress. Does emotional stress cause diverticulitis? That's the question of the week next week. If you're enjoying the Real GI Doc Show, please go on social media and leave me a like and a follow. Share the show with a friend or two. Send it to someone that you think is interested in this kind of medical stuff. And please leave a rating on Apple Podcasts. It's so easy to do. Just scroll down to the bottom and click the thing and leave a rating. It's super easy, and it will help this show reach some more people, and maybe we'll get some more good questions, and perhaps we'll reach some people where this advice will be very helpful to that would not even know about the show before. It's all good stuff. As usual, I'll be back next week, and until that time, keep doing what you can do to avoid all the bad stuff in life. Incidentally, that's eating healthy and not poisoning yourself. Concentrate on that this week, and I'll see you next time.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.